It was a great panel. I'll go on record, I'm not omniscient, omnipotent, or any of the above, but I did always like working with Rodney. We haven't been on a panel together, I don't think. So this was exciting. We'll have to do this again. I'll take the prerogative to ask a question or two. I will leave plenty of time for questions, discussion from the audience. The first question, just because I think we hit on this, but to sort of hit on it more directly, what are the 1 to 2 regulatory or policy changes you would make to ensure or incentivize higher quality care for people with serious illness? So to take the title of the panel and then ask it directly. If you had to pick 1 or 2 things from either a statutory or regulatory or other perspective, what would you do? What would you change?
I could start. Well, I think one thing is to sort of remove some of the barriers to folks being able to get palliative care, hospice care, remove the 6-month limitation, remove the need to have essentially a skill shown for something that's broader than just a typical Medicare benefit, and create a bundle of supports and services that Medicare is in the business of paying for, which we could call whatever we want, but at the end of the day, there are supports and services that help prevent declines.
There are much more creative things that I could say, but I'm going to say basic things. Reauthorize CHIP, reauthorize the DSNPs program, and pass the Chronic Care Act that Senator Wyden talked about.
I think every day forward that we move further and further away from classic fee-for-service is a good day. And Ido and his folks are a great example of that, because where you look at the work that Ido's folks do in any type of collaborative, a continuum of care model, they're incredibly important. If you look at it from a fee-for-service perspective, we look at it and go, how do we suppress that? If that's the way you think of it, particularly from a CMS-driven perspective, you go, we're doing a lot of that. Oh, and there's that imaging too. How do we suppress those? We've got to get out of a model that the payment structure is built on looking at utilization and saying, defaulting to its malutilization, and moving more towards let's land appropriate utilization and make sure that the payment systems respect that.
Go ahead.
Well, I was going to pick up on that because it's a good point. If you think about what hospices sometimes deal with high length of stay or low length of stay or live discharge and some of these terms that are tossed around, what it leads to is odd behavior. So, for example, if you're a hospice and you don't want to be hit with an audit, you may discharge live a patient who has been on care for a long time just because you don't want to be audited. But the result may very well be that Mrs. S ends up in the ER. She might break her hip. She might cost $1 million to the Medicare system, and she might end up back on hospice anyway. So what have we done? And in the siloed way that we think about providing fee-for-service care, and it's true of home health as well, we often lead to massively greater Medicare spending, and I think it frustrates CMS as well, because there's the hospice bucket, there's the home health bucket, but you're constrained, and part of the reason you're constrained is because of Congress, right? Because that's the way the law is written, and for one reason or another, those things have not been waived across the board.
I'm not sure that you need statute to do this, but there are some innovative companies that are in the direct primary care or even home-based primary care or even home-based pre-palliative care space that I think are advocating for the ability to have those services reimbursed in Medicare fee-for-service. I would be very supportive of that. I think that it's been interesting to hear and sort of read even in some of the materials and slides. There were a number of the federal government should, HHS should recommendations. There's an enormous amount of innovation happening in the private sector. Heard some about it today, but beyond sort of health plans or big organizations doing it, there are actually quite a number of venture-backed companies that are trying to figure out how to disrupt this space. And so I think creating more opportunity for those folks who have made those investments and also are really showing impressive results to have their models expanded and scaled would be really exciting. And again, I'm hoping that can be done administratively just because it would happen more quickly. But if not, then that should be built into one of these other vehicles that we talked about.
One comment that will lead to a question. So totally appreciate and understand, actually Rodney and I have talked about the sort of Hill CMMI dynamic before. I will say one benefit of CMMI and the sort of innovation construct from my perspective, and worked with all of you in different ways on models, is the amount of testing and learning and the cycle of change is much faster. I mean, if whether you say from 0 to over 30% alternative payment models, or now over 200,000 signed provider agreements, or over 27 million people directly in models and 200 million indirectly. I mean, that is a lot of testing, learning, changing, et cetera, which was exciting to be a part of. I do think, and I'll say that I didn't say this earlier, so I'll say it now. My hypothesis is that CMMI will be around and testing for a long time to come, for lots of reasons, and others can disagree with this once I ask the question if you choose so. But I think it's now at a place with a CBO score, but maybe more importantly, you've literally got agreements and providers and people innovating in every state community across the country, both in the public and private sector. So I just think that's hard to turn off or turn back, if you will. So then the question is, actually, one of my slight regrets, if you will, is that we had some great tests of models in serious illness, which I feel good about, and duals and others were named. It was one of those areas I never felt like we quite did enough. So if you said, what's the next generation or the next iteration of payment models in this area that you would see as promising, would love any of your thoughts on that.
Well, I think one of the things that I would say is that, one of my frustrations in a sense is that there were a lot of great models and there was a lot of great testing, and there's a lot of focus on the demos as an end in and of themselves. And I always viewed them as not an end in and of itself. The point is not to have a hospice concurrent care demo forever, or to have a duals demo forever. The goal, the end game, is really to create that lasting change, which may in fact require congressional action to actually change the delivery system. The one thing, I mentioned this before, that I felt like we were never really able to get at is getting at the reason why some people decline in Medicare. And Medicare has not enough tools to prevent folks from declining, a ton of tools to help people once they do decline. And if I could change one thing, it would be to really look at that medical necessity language and provide CMS with more flexibility under statute, not as part of a demo, to provide supports and services as a bundle.
So these will probably sound familiar to you because I probably said them when I was at the White House. But one is Medicaid, right? So I think that there are not as many levers for CMMI from a Medicaid perspective, but I'm hoping that we see more as it relates to innovation, Medicaid writ large, but certainly around their engagement from a complex care perspective. And then the second piece is thinking about how we bring in drug spending in either Part B or Part D, but bring in drug spending in more creative ways and accountability for providers, whether it's a primary care provider or a specialist in a bundle in a different kind of way. And I'll just echo, I think, Patrick's comments. Seema Verma, who's the administrator of CMS, gave a really powerful speech, I thought, a couple of weeks ago, and really outlined her vision for CMS, but talked specifically about an innovation agenda that was very compelling. And I think, sort of wearing my now private sector hat, an agenda around administrative simplification and trying to be really thoughtful about having the right number of measures for a particular area of focus, and also thinking about just the burden on providers from a paperwork and regulatory perspective. So I was really excited. I think a lot of my colleagues and a lot of the people that we're working with in the market. So that was really heartening.
I think that there's just an uphill challenge for, I think, what is the real, the real next the next wave of where we need to be in the payment side. The closest we got to it, I think, on the Hill, before I escaped, paroled, retired from the Hill, I worked on something called CBI SNPs, which was taking iSNPs and then expanding it to allow more community-based prior to needing institutional needs. And the idea was, again, just to go proof of concept. If you can do more early interventions for folks, even in a small scale, you can get proof of concept enough to ask what it would be like to go to larger scale. But the problem with going larger scale remains, and I think this is CMMI's problem, and my observation was that CMMI's challenge with looking at anything in the Medicaid or at duals was always the Medicaid program's approach to CMMI, which is keep your grubby little paws off of Medicare, especially if you think you're going to let states could do anything with the acute side. Oh, hell no, keep your grubby little paws off of Medicare, you states. And if you aren't going to look at, again, continuous care models where you're dealing with, which is, again, as we all know, the duals are extraordinarily expensive. And it is because they're in that transition from high cost acute needs into institutional needs, and we have the misalignment that neither program appropriately, my long-running joke, Medicare does not care, Medicaid is too dumb to know what's going on, and you end up spending a whole lot of money. And it's the institutional biases of both programs that prevent them from being able to have the right alignment. And I'm not certain that's anything we'll ever get from a CMMI perspective, unfortunately.
Quick question. So one of the things that was interesting at the sort of the end, last couple of years, was the PACE Innovation Act, where CMMI actually got the authority to waive the Medicaid side of PACE. Therefore, it had authority over all of PACE. And I wonder, in this world of streamlining, whether a system that allowed CMMI to have authority over all of Medicaid and move 1915, 1115 over there would be something that folks would find productive. I'm trying to throw bombs here, right? But it is interesting to me that there's an easy mechanism for waiving Medicare, and the way to waive Medicaid. There's two different channels, and at CMS, and as you know, those folks still aren't the same part of Medicaid, and OMB is involved, and the White House is involved, but it does seem to be very complicated to make any changes in Medicaid.
Yeah. I'll start, and then Julian may add more. Certainly, I think it will be a work in progress. I think over the last couple years, and I can't comment past September 15th, the relationship between the Medicaid, CMMI side, et cetera, got much tighter. And thinking about how you use all waiver authorities, including putting Medicare on the table. Now, the caveat, which is fair to Rodney's point, those came together in several states, but not 40. So I think the question on the table is, can you continue that momentum in this administration, the administration after that, et cetera, where you have state-based innovation that across Medicare and Medicaid is much more seamless, both internally to the federal government, but probably even more importantly, externally for actual people receiving the care in states. But I should let Julian add his.
So despite having only slightly tongue-in-cheek teased Patrick about the Medicaid piece, I think, there were things that happened behind the scenes that I think are promising foundations to build upon. So one of them is that the 1115 waivers, and for folks who don't have context, there's a provision in Title 19 of the Social Security Act where basically the federal government, through 1115 waivers, can waive significant parts of the statute and give states an enormous amount of flexibility to customize their Medicaid programs to meet their state-based policy objectives. And people have used those authorities to expand coverage in certain cases, to address delivery system reform objectives, and in other ways really try and sort of hone their programs around their objectives. It's an incredibly fraught and political process because just the magnitude of the dollars. So just for context, over a decade, the Innovation Center has $10 billion. In any given state, it could be $5 to $10 billion over a 3 to 5 year period for a single state in these waivers. And so the one thing I would say is I wouldn't want to do that to the head of the Innovation Center because It's them signing up for lots of meetings with governors and members of Congress and et al. Who have strong perspectives on that. But there are kind of hybrid ways. So one of the things is that there were folks from the Innovation Center who were actually involved in those 1115 processes, and there were ways to think about aligning some of the goals of things like a state innovation model, waiver, or program with things that you were trying to achieve in an 1115. Now the 1915s, that's interesting. I think that those those are more tailored programs. Those processes are not as political and not as fraught. I don't know that we made as much progress, if any, in terms of kind of involving CMMI in those conversations and processes. So low-hanging fruit would be, for folks to think about something like that, just leveraging the expertise, because CMMI has been able to recruit really incredible talent and diverse expertise, and probably the folks who work on 1915s could benefit from that, and the Innovation Center folks would learn a ton from the 1915 teams too.
I think what I want to come back to, though, is if you think about the challenge we face, go back to the couple I introduced earlier, which is the octogenarian couple, husband with Alzheimer's, wife with putting herself in the grave, keeping him up, and Medicare sees a clean claim. If I put a risk bearer who knows they're responsible for keeping those two out of an institution, which is a misstep away, I am going to put in edits into my system that tells the MD seeing that, listen, tell us. Because if you do, we'll order respite care, we'll order home health, we'll order home visitation, we'll order, how about we throw in some Meals on Wheels? We'll throw everything in the kitchen sink, because God knows we don't want both these two in a nursing home that we're paying for. And we'll reward that doc and tell her, we will pay you extra for sending us that warning. Okay? That's a system that achieves what we need to for the alignment of outcomes there. Now tell me how we can get Medicare to start thinking that way under current law, when Medicare looks at that and goes, Meals on Wheels, are you self-medicating? Do you think we're going to, what, did you just create an entitlement to food, you fool? I mean, that's what Medicare sees when I throw out something like that. And we have to be able to get across that hurdle.
I mean, in the duals demos, I think, and even in certain cases in Medicare Advantage or Medicaid managed care, I think you do see people doing some things that are more creative in that respect, less so in Medicare fee-for-service, although I think some of the Medicare ACOs have actually gotten as creative as they can, kind of flexibility-wise. But Rodney, one of the things that you said that resonated with me really powerfully, and I think was a big theme for the day, or two things actually. One is that we aren't thinking about couples as two different people who are potentially both Medicare beneficiaries and the interaction of their health, right? That was really a new theme for me today. It sort of seems like common sense once you say it, but I just haven't heard that at a policy conversation around that. But I thought that was actually a really interesting theme. So to think about them as a unit in some sense, and that if you're doing the right things to take care of the one who maybe some delta more sick than the other, you may actually impact the healthcare costs and the healthcare outcomes. So I thought that was really powerful. But the other piece is this idea that if you're more thoughtful about the broader caregiver supports beyond the spouse, the ways that you support adult children and others. We heard Ralph's family. Of course, they love him and loved his wife and their mother, but their own lives were complicated by the things that complicate all of our lives, right? Whether it's illness in certain cases, or marriage, or work, et cetera. And so that may be another place to think about more kind of creativity from a kind of caregiver supports perspective. And I will say on the commercial side, even beyond Medicare, there actually is a narrative among commercial health plans about making caregiver supports available to employees, commercially employed employees, because it's just such a huge component of their workforce productivity and, in certain cases, their own health and wellness.
The one issue I think that I've seen, and this is sort of the advocate in me coming out, is that there's a difference between an MA plan or an ACO being at liberty to, or being able to provide something either because they think it's a good idea or for whatever reason, and it being required. And that is a sort of a bit of a difference maybe in how we sort of think about this. But to me, and I think palliative care is a good example. Can MA plans provide palliative care services under contract? Yes. Can they contract with Tony's palliative care service to provide whatever Tony's palliative care service wants to provide? Yes. But there's a difference between that and having an actual benefit that you could put your arms around and saying, this is the benefit. This is what you actually have to provide. And I do think it's difficult to do that, put your arms around that with something like food or transportation, where the whole construct of Medicare is related to medical necessity. And we struggled in the demo in Massachusetts to say, by what metric do you decide whether or not it was medically necessary for Mrs. S to get this non-medical service? And how do you appeal that? But we need to be thinking about that.
But if you're paying for the institutional, that then changes everybody's calculus. And as long as you're not, you always have that end, well, Medicaid's going to get that. And as long as that's there, that's your cliff where you go, okay, I can do it. But at the end of the day, actually, I don't get, I mean, if I'm metrics that blah, 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 I don't have to pay for it. And that's where when I use that, it's savage to say it. Medicare does not care. The Medicare program does not care because it ain't paying for it. And that ultimately affects behavior.
I still cared. However, I think it's a great point on, and it goes back to some of the state-based things too. I mean, could you have a payment model where it was so interwoven that it was clear financially as well? Medicare will care, Medicaid will care, the state will care. I mean, it's it's a debt, and then we should open it up to the rest of the audience. It is a delicate balance. Having gone through some of these models, when we did say, hey, let's pay for food, transportation, social determinants, et cetera, and both of you will remember some of these. It was challenging, including challenging legally with our great lawyer colleagues about what was allowable, what's not allowable, why, how are you going to define it. It became really challenging, even if you were trying to interweave some of the social determinant of health and other sort of broader health issues into the Medicare program.
30 seconds, and I promise just to be, which is Medicare, doesn't care. Medicaid desperately cares. But that's where, again, I say very savagely, Medicaid is dumb as a box of rocks. Why? The Medicaid program doesn't know that octogenarian couple sitting in the doctor's office.
Can I be really annoying for 1 second? And
it's not going to be annoying. It's good. But then
sorry, no, you're great. So, I was always in this very awkward position of being a primary care provider who had taken care of patients who were participants in these programs and had a lot of passion around making sure they had the highest quality care, and being a finance person and certainly in a finance role at OMB. We do have a healthcare cost challenge in this country, cost growth challenge in this country. And I think one of the things that is really difficult is that, it is really easy to talk about adding additional benefits and services, right? But at a certain point, you have to think about the holistic trajectory of the Medicare program and the Medicaid program. We'll leave the other things, Social Security and all this stuff, but just the Medicare and the Medicaid program. And so, I have this conversation with folks, let's just use the case of housing, right? And I get in trouble a lot with my friends for saying this, but I'll just say it, right? So in a version of the world, yes, we have, it is a challenge that people don't have access to affordable housing. It's a heartbreaking challenge, right? And so you have people saying, well, Medicare or Medicaid should pay for housing. Was a conversation in Massachusetts, certainly was a conversation in various times at OMB. The OMB secretary, when I was there, had been the housing secretary, the secretary of HUD before he was at OMB. And I can tell you, this is actually a really complicated issue. And my answer to folks was, yes, we need to have policy conversations around how we're going to address the housing crisis. But the question in healthcare has to be, not should the CMS budget pay for all the housing needs in the country. It should be for a defined patient population. So can you actually say that for patients between 65 and 75 who have diabetes and COPD and XYZ, that when you house those patients, it has an impact on healthcare costs? You need to be able to do that to actually get support, because otherwise it really is just a slippery slope. If you move through the other social determinants from housing to education to workforce, et cetera, at some point it really, it breaks the federal bank. And so I think and you can have a lot of passion around the topics, but at a certain point, you really need to get to a place where you're building an evidence base around how addressing specific social determinants has measurable impact on health outcomes and on the total cost of care, or there won't ever really be support for doing this at scale.
That was not annoying. It was an on-target comment and made a lot of sense. Let's open it up. There's microphones, at least on both ends of the room, if people have comments or questions.
Okay. Hi, I'm Judy Paris with the Social Work, Hospice, and Palliative Care Network. And I came in with the Medicare 1972 amendments. So I've been at it for a while, including a lot of years where we talked about it was important not to over-medicalize long-term care services. So I want to build on the last thing that we were hearing. What do you think it would actually take? And I should say Dying in America calls for the harmonizing and merging of some of the medical and social support funding streams. But if we talk about targeting that slim population that would need housing, transportation, Meals on Wheels, how would we even begin to address that through either the waivers or, who knows, in this period of time, some sort of statutory changes? What would you see that we actually would need to be doing?
So I would say a couple of things. One is that, and the Commonwealth Fund has a great slide that if you don't have it in your deck when you guys all give these talks, it's a great slide to have. But it basically compares U.S. healthcare spending and social services spending to other OECD countries. And the takeaway is we always complain and say we have the most expensive healthcare system in the country and we don't have quality outcomes. When you look at those bar graphs, it actually shows that the combination of healthcare and social services spending, actually a lot of similarity in the level of spending across OECD countries. Now, obviously, they're getting better outcomes. They're spending more on social services. We spend more on healthcare. That said, my push is always, because ultimately, again, to align budgets across, various components of HHS and other departments like HUD and, depending on how far you want to go down the spectrum to education to, what have you, would be a massive, massive undertaking. Not necessarily impossible, and you have to have big dreams and a vision for where you want to go. So I think there absolutely should be people thinking about how you ask and answer the meta questions. There are ways to think about doing blended funding, right? There were actually there was a period of time where there was the ability to combine Medicaid dollars and dollars from some of the other health-related social services agencies to make some investments in technology, for example, a narrow window of time to do some blended funding around that. There are Medicaid programs today that are using Medicaid dollars to provide coordination to help people get access to housing benefits that already exist. So my push is always, while a certain number of people need to be thinking about the macro questions and how we would get there and get there in a way that's measurable and outcome-based, there's an enormous amount of work that could be done to actually build up a more robust evidence base so that when you have to come and meet with CBO, for example, you're able to bring data because that's what they're going to do their scoring around. And if you're ever trying to get something done, as Rodney sort of helped to remind all of us, you're going to need a CBO score ultimately, and they're going to want to see the published literature on how, again, specific services for specific populations have a measurable outcome. At a certain point, you can get to crazy things like dynamic scoring, which are a part of the conversation today around some of the other things that are non-healthcare related, but that are actually very relevant for this topic because some of those benefits would actually need that type of scoring approach probably to ever get support.
Thank you.
I'll just briefly add on. I think there's potential if you have some states and communities that have alignment of governor, Secretary of Health with purview across everything, Medicaid, social, et cetera. Actually, North Carolina has some of these components, by the way. Medicaid, managed care, so really managing the entire population. The ability for the federal government to think more creatively about Medicare in that given state with all of its waiver authorities, whether it's CMMI, 1115 in the Medicaid space, et cetera. I think you could have some state and community-based models that show what's possible and then help with the federal discussion.
Hi, I'm Allison Silvers from the Center to Advance Palliative Care, and picking up on everything that you're talking about, I've been chewing on that there's pockets of innovation and pilots and evidence that's accumulating, but I guess I'm struck that one of the big barriers that I haven't heard mentioned yet, and when you mentioned the Commonwealth slide, the Bradley analysis, is that that money is already being spent and it's supporting institutions that employ a lot of people. It's, I'll pick on surgeons. There's already money going into procedures that are happening. So some of this is actually, if we're not going to just keep adding costs to the healthcare line, means that it has to be reshuffled, and there's losers in reshuffle, and even some hospitals, I'll pick on hospitals, that support that reshuffling don't know how to get from here to there. I don't expect any answers, but I'm curious about your comments.
Well, I can give you the politically tone-deaf answer, and that would be, and Rodney, I'm interested in your reaction to this. But it is interesting that you have access to anything that's medically necessary. And when I was at the Medicare Rights Center, I could get you anything you wanted under Medicare, even if I needed to go through the appeals process. But if you want access to palliative care or supports and services, you either can't get it, or you have to work really hard, or you have to be dying. At some point, the elephant in the room is the proportion of palliative care to anything you want has to go like that as you move on. And some of the advanced payment model proposals do that, kind of. But I think if we're really going to have a serious conversation in this country about how to get access to more stuff, we're going to have to do two things. We're going to have to believe that access to more supports and services will lead to less access to, not because you don't have the access, but less accessing of more expensive care under Medicare. And also, Medicare has experimented with access, making it more difficult to access certain supports and services, DME, for example. It's not that you don't have access to DME, it's that there are some hoops you need to jump through in order to get that DME, power wheelchairs, for example. Medicare has started to say, you don't have a blank check when it comes to access to certain things that happen to be very expensive. If that trend continues, I would hope that one would look at easing the access to other services that happen to be less expensive and perhaps more effective. That's my, now it's tone deaf because that's called rationing. I would say that in a second if I were on the other side. Rodney, do you want to call that rationing?
It's pretty damn close.
Yeah.
I mean, it's in the neighborhood. We're in, it is a cultural shift that we are going to take, it's going to take us a while to get to. Because, and it speaks to the entirety of the challenge we face in policy, and I would argue healthcare policy in dealing with people who are over 65. Because when people retire, this is their expectations, right? I'm going to live a long and healthy retirement until at an appropriately old age, I am going to pass away in my own bed, surrounded by my family and angelic music. And you never spent a day in hospice. You were never in an LTAC. You never had acute incidents. You never had extended stays. None of the things that are actually the real world happen because you don't think of it that way. And it doesn't matter how much any of us go through that with our parents, that grandparents, that cultural change is still so far off that we come to approach 65 on with a more realistic expectation of what that's going to be, which is it's going to end. And that's something we struggle with so mightily, that in terms of aligning what our policies are, that are how do I want to go, not how do I want to fight like hell the whole way. And that's never going to be easy. And particularly, and I'll throw on the conservative hat, and you want your government involved in policies that direct how that ends up? Heck, I don't have to have a black helicopter and live in Idaho to question that. I mean, that's going to cause people to be very uncomfortable if your benevolent government is helping design those policies. And that's where, again, perhaps dealing with things like ACOs, APMs, other things there where you have people who, I mean, it's, all right, so we've all done sort of the, you know, our personals. I mean, my grandfather, deep with Alzheimer's, you know, he is to the point where we're near the end, and you know, that he is no longer eating, you know, can't keep food down. And so goes to my grandmother and says, okay, well, you know, maybe we could do a PEC tube and feed him that way. And the doctor got on the phone with me, and because I had power of attorney, but this was like, it came to me too late. And he talked to me, and it was only after I had this opportunity to step back and that I realized what he was telling me is he's so far gone he can't eat. And we're done here, okay? But he couldn't say it that way. And it's, can we get to a world where providers have and we're in a comfortable world where you just say it that way? Just say it, okay? He can't eat, and we're done here. So let's enjoy what we have and move forward instead of saying, okay, how about a PEC tube? I mean, that's where we need to get to, but you can't do it through payment models. Or
Yeah,
government payment models.
Yeah, so agree on the cultural aspects, and that hits on both cultural aspects of providers and sort of broader cultural aspects in training. The one thing just on the macro question, I wrote an editorial for a JAMA paper that I didn't write, but it was really, I don't usually write editorials, but it was so interesting, I was like, I gotta write one. It looked at cost trends and why we're having a problem. About a third of it is aging population, et cetera. You can't control that. About half was prices. And primarily, and this is just data, not pointing fingers, hospital-based prices and pharmaceutical prices. And so, you know, those are two large elephants in the room or factors or data points that as a country, we may want to deal with if we actually want to have resources to pay for K through 12 education, the rest of healthcare, serious illness care, hospice, palliative care, et cetera. Any other last comments before we do the closing?
I'll again try not to be provocative, but you went there, Patrick. So on the hospital piece of what you just described, and I guess a different take on your question, if a hospital or health system is an arrangement where they are accountable for the total cost of care, and we get to a place where they have greater flexibility around how they provide services, then it is possible that they will have a similar budget, or ideally a bit less, for all the reasons that Patrick outlined, but actually use those dollars in different kinds of ways, and think differently about whether they see their bed as a cost center and whether maybe they would actually deploy some of those dollars in different ways outside of the hospital's four walls that have a greater impact on improving health outcomes, but also helping to slow healthcare cost growth, right, on the hospital side. The pharmaceutical side is much more complicated, but what I will say is, beyond kind of the existing pricing challenges, the reality is there's an extraordinary amount of innovation happening right now, and work on treatments that have the potential to either have a significant impact on morbidity and or mortality. And so it may, in one version of the world, the question is how big is that pie and how fast is that pie growing, or how it's allocated. I see it differently. Even if it's the percentage that it is today, because of the amount of innovation that's happening, we're going to actually have to have additional capacity to be able to finance the innovation, right? So it's in both cases, you know, I think both of the house of hospitals and health systems and the house of pharmaceutical companies have to kind of think about how the dollars are allocated internally to the systems. I mean, ideally you might think about the trajectory, but internally to the pie, how they're allocated over time. Because my bigger concern on the pharmaceutical side is I'm thrilled about the amount of innovation. How do we think about our total healthcare spend as a component of our total GDP and what that trajectory looks like over time? The pharmacy piece as a component, recognizing that we need the innovation, but we have to be able to afford it, and how do we strike the right balance?
So I want to thank all the panelists for a great panel. Please join me in thanking them. Over for closing.